Appendicitis. Diagnosis. Symptoms. The classic triad is pain, vomiting, and fever. Abdominal pain begins in the mid-abdomen or periumbilical area. Pain most often localizes to the right lower quadrant after 4-6 hours, but this is variable, depending on the anatomical location of the appendix. Vomiting usually follows rather than precedes abdominal pain. This may be less consistent in young children. Vomiting occurs in about 80% of patients, and generally occurs only once or twice. Low-grade fever usually develops after the onset of abdominal pain. Anorexia is quite common and is seen even in young children who cannot verbalize feelings of nausea. Some say the diagnosis of appendicitis should be questioned if anorexia is not reported. Most patients report obstipation before the onset of abdominal pain, but 5%, 10% report loose stools. Signs. Guarding and focal peritoneal signs are expected. Pain in the right lower abdominal quadrant. In 2/3 of patients, this finding is not present when the child has an appendix in the pelvis or retroperitoneal area. Suprapubic or flank pain may be present in those cases. Shaking the child, precipitating a cough, or asking the child to hop on the right foot may help to localize the pain. Patients usually prefer to lie quietly, as movement increases the pain. Rectal examination that elicits sudden pain, as opposed to discomfort from the examiner's finger, confirms the presence of inflammation and is found in 50%, 80% of cases. A boggy mass suggesting an abscess may also be palpable in 25%. Rectal examination is especially helpful if the appendix lies in the pelvis. Psoas sign. With the patient lying on his or her left side, the examiner should slowly extend the right thigh. This stretches the psoas muscle and produces pain. If the appendix is inflamed, obturator sign. Passively rotate the flexed right thigh internally with the patient. Supine. Irritation indicates a positive obturator sign. Peritoneal signs. Inconsistent investigations. Complete blood count generally reveals an elevated white blood cell count early in the course. A left shift is noted later in the course. The white blood count will be markedly elevated with a left shift if perforation has occurred. Urinalysis shows ketosis and sometimes a few white blood cells if the appendix lies over the ureter or adjacent to the bladder. Abdominal radiographs. Often normal, but they reveal a fecalith in 8%, 10% of cases. Many consider radiographs to be unnecessary in making the diagnosis. Most radiographs show diminished air in the gastrointestinal tract from anorexia, nausea, and ileus, air, fluid levels, and indistinct psoas margins with scoliosis concave toward the right. Air in the appendix is also noted in some cases. Free air in the abdomen may be seen if perforation has occurred. Abdominal ultrasound, helpful if there are equivocal signs and symptoms. This study is sensitive in 85% of cases with a specificity of 94%. The probability of appendicitis after a normal ultrasound is 6%. Surgical consultation, indicated when the diagnosis is clear or when
gastroenteritis, expect nausea, vomiting, and diarrhea. Urinary tract infection, expect more white blood cells and bacteria in the urinalysis. Constipation, fever is unusual. Lower lobe pneumonia, usually associated with cough, fever, and tachypnea. Pelvic inflammatory disease, surgical consultation may be warranted. Renal colic, expect more red blood cells in the urinalysis. Complications. The condition is misdiagnosed in 7% to 12% of patients aged less than 15 years, and in 57% of those aged less than 6 years. Perforation occurs in 25% to 30% of cases. In preschool children, perforation is noted in 50% to 70%. Once perforated, there are usually signs of generalized peritonitis with a rigid, tender abdomen. The child will appear quite ill, with pallor, dyspnea, and grunting. Radiographs may reveal free abdominal air in these cases. Pharmacologic treatment. Antibiotics are recommended. Standard dosage ampicillin 200 mg per kilogram per day. Gentamicin 7.5 mg per kilogram per day. Possibly clindamycin 25 mg per kilogram per day. Non-pharmacologic treatment. Surgery is required after appropriate intravenous hydration and stabilization. Management of pain and fever are also important. Placement of a nasogastric tube may provide comfort preoperatively. Important information. Do not ignore the findings of abdominal tenderness, especially in the lower right quadrant. Since the diagnosis is often difficult, it may be wise to admit some children with abdominal pain to the hospital for close observation, even if their initial presentation is not classic for appendicitis. Admit the child who has any two of the following three indicators: classic history, impressive physical examination, abnormal laboratory studies. This will allow for re-examination every 1 to 2 hours. Re-examination of the child at several points in time is crucial, because the findings will change as the condition evolves. Remember that tenderness may be lessened temporarily if the appendix has recently perforated. Radiographs, if obtained, should be carefully reviewed and acted on when abnormal. Consider evaluation of the abdomen with ultrasound if the diagnosis is not obvious. Document the findings of abdominal and rectal examination carefully. To correct metabolic acidosis and electrolyte abnormalities. To restore hydration. To remove the inflamed appendix. Prognosis. Prognosis is quite good after surgery. In cases of perforation, prognosis is also favorable, although the hospital course may be prolonged by several days. Mortality is 1%, 3%, and death usually occurs in misdiagnosed patients. Follow-up and management. If the diagnosis is suspected but is not confirmed and the child is discharged, follow up within 12 to 24 H.